Hmm. We'll get started in just a few more minutes. We'll get started in about 2 more minutes, just giving time to let everybody join in. Um, Usually people join right at 7 o'clock and find out that they have to update their Zoom client, so it takes them a few more minutes to get in. So we'll give them about 2 more minutes and then we'll go ahead and get started. All right. Good evening, everyone. My name is Patrick Botts Forbes. I am the LAFD Community Emergency Response Team Central Bureau Coordinator. I'm also an LA County EMT. And tonight is our third Wednesday of the month, continuing education training for Community Emergency Response Team. Tonight's topic is going to be on patient assessment, more than just head to toe. As a baseline, we really want to talk about what the goals of the Community Emergency Response Team training is. Those of you who've just taken the training and have not actually been able to get out to any of our exercises or drills, or have ever have deployed during a disaster, a lot of this is book learning and maybe just hands-on stuff you've done in class. But there's a few things to remind yourself of every time you try and help someone else, be it in your personal life or during a disaster. And that really is that CERT CERT does the greatest good for the greatest number, and this is important in the shortest amount of time. Um, a lot of times we overthink things, and as we are trying to help, we try and remember our training and all the possibilities and end up hesitating. And they say that oh, I'm blanking on the term, but basically, if you don't do something, someone is going to die. If someone's bleeding out on you and you don't stop the bleeding, they will stop having enough blood in their body to circulate blood and circulate oxygen. And that will take care of itself in the opposite way that you actually want to help them. Also, when we are trying to help, we never bring a victim to an incident. And we've heard stories about during drills where there is someone who needs help. It's in a moderately damaged building, and they've suffered a trauma and they can't be safely removed without risking additional injury to them. However, suddenly the building becomes unstable, and now time is a essence of getting out of the building. Do you risk paralyzing them by rushing them out of the building, or do you take the time to safely lift and carry and hold C-spine and make sure that they don't suffer additional injury? If you take too long to do this and it's unsafe, then there's a greater possibility that not only does your survivor or patient die, but you do as well. So we have to keep that timeline as a priority. Do what you can as quickly as possible with the amount of resources that you have, and don't overthink it. When the professionals are not there, the training teaches us to be the first responders. A lot of times they tell us, of course, CERT never self-deploys, but if there's an emergency right in front of you and you can do something about it and you want to do something about it, then you should do something about it. You are the first responder until first responders arrive. During a disaster, what you do in the first hour will save lives. Um, Keep in mind that the whole purpose of CERT is the understanding that there are not enough professional first responders to help everyone during a disaster. And the whole reason we take this training and why this training exists is to give us the tools and the foundation, the fundamentals to help our neighbors, our fellow citizens, our fellow community members, um, before the professionals can arrive, or unfortunately, maybe it's going to take them a lot longer than we would like. And so if we wait, people will die. But if we can do something about it, we can save lives. Do what you can with the resources you have. You're never going to have as many resources as you need or you want. Certainly, most of us, or I don't think any of us, walk around with an entire ambulance full of tools and medical supplies and equipment. Sometimes you need to extricate somebody and you don't have the proper lift cribbing or whatever, and you have to improvise. You have to come up with a solution that may not be the greatest or the best, but it works. Of course, don't do something that's going to put someone else at risk. Don't put someone in additional danger by doing something that's unsafe just because you don't have the proper tools. Um, you never want to hurt someone more than you need to, but keep in mind that time is of the essence. If you don't get someone out and the building collapses on top of them, they're going to die. If you injure them because you had to get them out quickly, you're going to have to justify this. Um, Good Samaritan talks about how we can't be um, held liable for helping someone out of the goodness of our heart, but that doesn't mean they can't sue us or they won't sue us. So really think through what you're doing. Understand that you need to be able to justify your actions in a court of law when someone is threatening you and your livelihood and all of your money just because you wanted to help them. And some lawyer said they can make millions of dollars because they were in this disaster and somebody helped them. And that happened to be you. Keep that in mind because also that might be a reason not to. I'm sure if you're on here, however, if you're taking the time out of your Wednesday to come join us, or if you've taken, a 20-hour class on how to help your community members, help your neighbors, that this is something you want to do, but you need to have that full understanding that there are risks and consequences, and it might be expensive. Um, the other thing is that it's very important to pre-plan. It's very important to come up with a plan that you're going to think through, at least have a basic flow chart, basic, I'm going to do this, then this, then this, then this, with the end goal of being this. Now, no plan survives first contact with the enemy or incident. There will always be something that goes wrong or not according to plan, not according to your plan, especially. So you have to constantly reevaluate what the situation is, what the circumstances are, any new information, any new changes, any new circumstances, and be ready and able and willing to pivot, shift, and adapt. Because if you continue trying a plan that does not work, not only is it going to be frustrating, but it the definition of insanity is doing the same thing over and over again, expecting the same result or expecting different results. And then when the professionals do arrive, you can continue supporting them as a force multiplier. Purpose of this training is this is not something you're going to get a piece of paper saying you did this. It's not something you can show your employer that you did this. The reason why you're here is because you want to learn more. The whole point of continuing education is understanding that the basic training you took in class is not enough. The basic training that you took, you're going to forget. So these trainings are designed to really reinforce the things that you've learned, introduce new topics, new information, things that go above and beyond the scope of the basic training, um, and then help you think about how you need more training. I don't know who might have taken the training and felt as soon as they graduated that they can go rescue anybody and they don't need any additional training. But the simple fact is that professionals, EMTs, nurses, doctors, um, all have to take additional continuing education training credits because it simply isn't enough to do the bare minimum. There always going to be things that change, always going to be updates, always going to be new information. And so it's really critical to be able to continue to learn and seek out new opportunities for training and hands-on opportunities to reinforce the training that you have. This training is going to be one way you can do things. It's not going to be the only way. It might not be the best way, but it is an example of a way that may work. You're going to have to customize this for your own needs, for the needs of your team, for the needs of your community. Um, as I said, no plan survives contact with the incident. So you may pre-plan everything, and then as soon as the disaster occurs, you're going to realize something didn't follow the plan that you expected, and now you're going to have to adapt and change. But if you understand the destination, where things should go, where things need to go, then at least you have a roadmap on how to get things back on track and where you need to get them to go, even if you have to get out and push. The purpose of emergency management is, and I think you can actually redefine emergency management as controlling chaos. A disaster, an incident is chaos. An emergency is chaos. And it will be um, probably not the way you expected it to be chaos. It will be something completely unexpected. The whole point of this training, the whole point of emergency management is to figure out how to make chaos less chaotic, how to control chaos, and then how to get things back to normality, back to the way things were. But keep in mind that after a disaster, things will never return back to the way they were. A new normal will occur. Emergency management is all about getting that chaos under control until that new normal uh, arrives. And for those of you in the LA area or willing to travel, LA City Fire is putting on a CERT refresher on Sunday, April 26th. It's going to be at LAFD Fire Station 88 in Sherman Oaks, 5101 North Sepulveda Boulevard. It is open to all CERT graduates. Now, if you're not CERT trained yet, unfortunately, this refresher is not for you. This training that you're currently on either Zoom or on YouTube, if you're watching this online, is open to you. We encourage you to take the CERT training. You're going to learn a lot here, and then you're going to learn a lot more in the CERT training. But for a CERT refresher, it is open to graduates only. You do have to wear closed-toed shoes and long pants. That is a hard requirement. We ha often have people coming in sandals, and the environment is not safe to walk around in sandals in, and you will not be allowed to participate. It is stacked parking, and we've seen people come, get in the stacked parking, and then get told you can't be here without closed-toed shoes, and they're wearing sandals, and now they can't leave. So uh, please wear closed-toed shoes and long pants, preferably boots, preferably some sort of pants that are durable. You might be doing kneeling. You might be um, having to crawl on your knees if you're doing search and rescue. And you don't want something thin and flimsy that might tear or shred easily. Helmet, you should have hopefully gotten a helmet, goggles, dust mask, gloves, in your kit when you graduated. If you didn't, hopefully you um, can get that before, or we might have loaners there as well. And then bring your lunch and drinks. Um, on Saturday, April 25th, Venice CERT, that's under CERT, LAFD CERT Battalion 4 with Jose Morataya, is doing a evacuation center exercise for a tsunami scenario. I don't have a slide for that, but maybe Jose can post that in the chat, and hopefully you can attend that and get some additional training that way as well. I don't, there's not going to be a catered lunch for this refresher. As you can see, we're probably leaving at 1 p.m. So you do want to bring something that you can eat, drink. You might have an opportunity to break for lunch, or you might have to go between rounds. I don't know how the refresher is going to be staggered, but it's a good practice on keeping yourself nourished during a real disaster. You're going to be out there for more than, a few hours after a real disaster. So going back to this training, um, the question is, when does CERT do medical? And it really is when it's safe to do so. We don't bring a victim to an incident means that we don't put ourselves at risk to save others if we can't do it safely. That is fundamentally the point of the Community Emergency Response Team program and training is the 1986 Mexico quake. LAFD went down to observe and assist and saw the community helping one another after this massive earthquake in Mexico City. The next morning, there was an aftershock, and people were going into buildings that were not safe. They did not have the training, they did not have the understanding of what needed to be done to keep themselves safe. And unfortunately, a lot of volunteer community first responders died when that aftershock occurred and buildings collapsed on top of them. So we always keep at the forefront of our mind, is it safe to enter? Is it safe to do this? Is it still safe to be here and continue helping? If something changes and we need to get out because it is no longer safe, then we need to do so. And a lot of the training goes towards breaking us of what's called tunnel vision. When we're helping someone, we tend to focus on what is right in front of us. And if we're having someone screaming for help and we are tunnel visioned in on them, we're helping them. We're no longer paying attention to what's going on around us. We're no longer paying attention to the smoke building in the room. We're no longer paying attention to the lights flickering above us and that crash as wires come down and we happen to be in water. We're no longer paying attention to, um, are those cracks in the wall getting bigger? We're no longer paying attention to the things that might kill us and our patient. And so not only is it important to keep um, awareness of our surroundings and situation, but this is why we have the concept of a team and a team leader. A team leader is going to allow their team members to focus on helping, while the team leader focuses on keeping the team safe. And so, when does CERT do medical? When it's safe to do so, fundamentally. We're going to do an initial triage. We're going to find out how bad it is. And then we're going to, if it's not safe to be in there, get our patients out. We're going to set up a medical triage or a medical treatment area somewhere close to the initial incident. We don't want to have our rescuers carry people 5 blocks to a medical treatment area if they don't have to. But we need to make sure that medical treatment area is safe enough in case something happens and say the building collapses or explodes, that it's not going to kill everybody that is right next to it, doing medical. Um, Additionally, it's important to keep in mind that when we set up a medical treatment area, we need to have an exit plan for our survivors, for our patients. And they need to be probably transported, probably by vehicle. So is this close enough that a vehicle can come and then you just quickly load them into the vehicle, or you're going to have to cross an entire field to get to the vehicle to get your patients out? Um, and this may be an ambulance, or this may be a neighbor's vehicle or a community member, someone who wants to help, um, because the professionals are busy. They're busy somewhere else and not where we want them. We're going to have to improvise and come up with our own solution. We're going to do medical if we expect that there's going to be a large number of injuries due to a local disaster. CERT patient assessment is a little bit different than patient assessment at any other level. I mentioned I'm an EMT. EMTs, generally speaking, have an ambulance. That is really what makes a professional EMT different than a community responder. Yes, we have a little bit more training than you do, but I'm sure there's people on here with more training than I have. Um, if you have an ambulance, you have equipment, you have a vehicle, you have gear. If you're working at a hospital or you're working at a sporting event with a medical center, you have equipment and gear. If you are a community responder, maybe you saw a car crash and you pull over and get out of your vehicle. Do you have a trauma kit? Do you have an AED? Do you have oxygen, airways, a C-spine, a way to extract someone from a vehicle? Do you have the jaws of life? Do you have a chainsaw? Do you have cribbing to stabilize the vehicle? Chances are no, to a lot, if not all of that. Now, you might have a basic first aid kit. Um, More and more we talk about having a tourniquet, a commercial grade tourniquet in your first aid kit at even a basic level. Do you? If you need to stop someone with a femoral bleed and you don't have a tourniquet, an improvised one is going to take time to make and will be less efficient than a commercial grade tourniquet. And in this case, if someone is bleeding out from a femoral bleed, they can die within 3 minutes, maybe less, and you need to stop that bleeding immediately. And if it takes time to improvise a tourniquet, and I'm not even talking about trying to take a belt and turn it into a tourniquet, I mean trying to build some sort of tourniquet with strips of cloth and a windlass, that person is probably going to bleed to death before you have that opportunity to put that tourniquet on. Yes, you can apply direct pressure and try and slow the bleeding, but while you're doing that, are you going to be able to build a makeshift tourniquet? So start thinking about what you have with you and carry with you, because that might be all you have. Um, but again, we're not professionals. We don't have an ambulance. There's a limit to what we can do and to the equipment that we can carry. I don't know anyone who's taken the CERT training and carries cribbing on them. I'm not entirely sure who's going to tear down a fence and make cribbing to stabilize and then use a lever to lift something heavy off of someone. However, there is stuff that we can do. We can have a basic first aid kit with a tourniquet. And that might be the difference between saving someone's life and letting them bleed to death because we don't have the proper equipment. CERT patient assessment is an ongoing and continuous cycle of evaluating life threats, providing immediate and secondary interventions, and planning for definitive care. And that last part doesn't get talked about anywhere near enough. We talk about doing first aid and treatment on a medical tarp, but we never talk about, or very rarely do we talk about, how are we going to get these people off the tarp. We assume and hope that the fire department's going to come pick them up. But in a real disaster, the time it's going to take for an ambulance to show up when you want them to is going to be way more time than you actually have. It's going to be way longer than you hope it's going to be. And so we need to start thinking about as we pre-plan, but also as we're helping our neighbors, how are we going to get these people to definitive care? And if you're not thinking about that, you don't have an exit strategy here. Patient assessment doesn't just happen at the medical tarps or the medical treatment area. It happens as soon as you encounter someone who is going to become your medical patient. If you see someone walking along and they don't look right and they start to stumble, and you have basic medical training and realize this person is probably going to fall. This person may hit their head. This person may pass out. You're doing patient assessment. You're looking at someone and trying to figure out what is going to kill them and what is possibly wrong with them. And is there something you can do to mitigate this problem? I mentioned a few times planning, pre-planning, having an idea of what am I going to do? Where am I going to go? And this really needs to be done before a team even goes out. Before you decide you want to help your neighbors, you need to have some sort of idea of what am I going to do for them? More importantly, what am I going to do when I encounter someone who needs to go to the hospital? I need to have that plan at least somewhat thought out. Even if that plan is not going to work the way I want it to, I need to have that strategy. I need to figure out how am I going to get someone to the hospital before they die on me. When we talk about primary assessment, we're really talking about evaluating life threats. But I want to reemphasize it is not just life threats to the patient. Is the scene safe? In all medical training, in CERT, in first aid, in EMT, in EMR, paramedics, the first thing that gets asked is the scene safe? For me, for my partner, for my team, for my patient. If it is not, we don't go in. Now, this is going to change depending on who the patient is. If the patient is a family member, you're probably going to go in, and no one is going to blame you for doing that. If your child, your significant other, your parent is inside a building that is on fire, is it safe to go in? Hell no. Are you going to go in and save them or attempt to save them or risk dying to save them? That's a personal call. I would guess more than half of us would say yes. Is it worth that risk? Probably. But again, it's a personal call. Is it worth the risk of dying in a fire to help or potentially help someone who you don't know? Again, that's a personal question. But if you die in the fire, you can't help them. But also remember that it's not the fire that's going to kill you, it's the smoke. As soon as you take just even a small breath of that smoke in, you're going to be on the ground unconscious. And then you can't help anybody. And then you die in the fire too. Or someone else is going to risk their life trying to save you. So if the scene is unsafe, or it was safe, or you get in there and now it becomes unsafe, or things change and it is unsafe now, how do we get out? How do we get our patient out? Do we quickly grab and run? Emergency extrication? That is, we're not taking any extra safety precautions to prevent additional harm to our patient because if we don't, if we take too long, we're going to die and the patient's going to die? Or is it so unsafe? Maybe they're trapped, they're pinned under something, and the fire is now causing smoke to fill the room, and we have seconds to get out of there. Do we abandon our patient to save ourselves? Goes back to we don't bring a victim to an incident, but we can't help other people if we become victims ourselves. After verifying the scene is safe and reevaluating constantly to make sure that the scene is still safe, we need to do a primary assessment on our patient and um, any immediate interventions that need to be done as well. Now, we talk about an EMT and basic first aid, the ABCs. This is also something we talk about in CERT as part of triage is 32 can do. Is the person's airway open? Are they breathing? Yes or no? How fast are they breathing? Are they breathing more than 30 times a minute? That's every 2 seconds. Are they breathing way too slow? Um, do they have correct circulation, perfusion? Is something wrong with their blood circulation? And that is going to be in the CERT language, checking their capillary refill. Is it greater than 2 seconds? For more professionals, you're going to check for a pulse in their wrist or near their behind their ankle. And the reason is that you want to know how well the heart is performing and perfusing blood to the system. But this is also going to tell you, is the person going into shock? If they don't have good skin perfusion, something is wrong. Something is very wrong, and the body is reacting. Either they've lost too much blood, or the body is in a fight or flight mode and is trying to preserve itself by drawing blood away from the fingers, from the toes, from the extremities into the core of the body to preserve itself for as long as it can so that it can get help. This is where we start to assess, and we when we talk about 32 can do, we often do tests and provide scenarios to get you to think. Is someone injured enough that they have a capillary refill above 2 seconds. And the reality is, if anything severe has happened, their capillary refill will be above 2 seconds. And so you're assessing this and determining that they are now in shock and we need to take additional precautions, and it increases the priority of getting this person in the hospital. Because once the body goes into shock and starts to try and save itself, it is not reversible by us. They need to go to the hospital. And this is not something that they can just wait because they're a little cold. And if we give them a blanket, they're going to get better. That last part is added on to the ABCs. And it's something that we always need to think about. Another way to determine that is, can they follow directions? If they can't, then something is wrong. Maybe they got hit in the head. Maybe they don't have enough blood flow to the head. Maybe they're having a stroke or something else. But it is a critical problem if they can't follow basic directions and they need to go to the hospital. Now, one criticism about triage, the basic start triage, and following ABCs is that at what point do you address severe bleeding? It's not really here. And so there's another acronym, MARCH, which stands for massive hemorrhage, airway, respirations, circulation, and hypothermia. And you can see how it's really the ABCs, but they threw massive hemorrhage in beforehand. Now, it should actually be the second thing you look at. Because, yes, if they're squirting blood and you don't do anything about it fast enough, they will bleed to death. However, if they don't have an open airway and they're not breathing and you can't get them to breathe, they might still have a heartbeat. They might still be spurting blood. And if you use a tourniquet on them, you might have wasted that tourniquet. Or worse, two tourniquets on someone that you weren't able to save because their airway has collapsed and there's nothing you can do to get it open. But these are things to think about. Once you verify the person is breathing and you see a pool of blood underneath them, or you see literally blood squirting out of their leg, do something about that. Stop that bleeding before it kills them. Because if they don't have enough blood in their system, it doesn't matter how fast or how slow they're breathing, eventually that breathing will stop. And then treat them for hypothermia, treat them for shock, keep them warm because their body is going to be compensating and it's going to need all the help it can get to stay alive. So I touched on some of those immediate interventions. Um, but what happens if you encounter someone who's not breathing? Well, the CERT training says give them a chance, open their airway. You don't know why they stopped breathing, but they're not breathing. That's a problem. That will kill them very, very quickly. So if they're not breathing, attempt to open their airway. Do a head tilt chin lift, or if you have time and you suspect trauma, that's to the back, to the spine, to the neck, or to the head, you want to do a modified jaw thrust to lift the jaw and the tongue, which is attached to it, away from the airway, pulling the tongue away so that they can get air. Most people, most adults, um, their airway is impaired because of the tongue falling back. They can't swallow their tongue, but it can fall back and occlude their airway. And just by doing a head tilt chin lift, that's tilting the head back, lifting the chin, or doing the modified jaw thrust, you're pulling the tongue away from the airway and giving them a chance to breathe. They will probably gasp for air. If they do, great. If they don't, give them a second chance. Let go. Let the body reset and then attempt one more time. If you get them to start breathing, now you need to maintain that airway. Um, you're not going to sit there holding their uh, head tilted back and their chin away from their face or doing the modified jaw thrust. If you have someone who can help, yes, you can have that person hold and maintain this person's airway. However, what you don't want to have happen is you let go, tongue falls back, and they stop breathing again. So what you can do is put something underneath the back of their neck, roll up a sweater, sweatshirt, something. Um, Even a book can go under the back of the neck, and that's enough sometimes to keep that airway open, keep the tongue away from the airway so they can continue breathing. Again, massive hemorrhage. Do something to stop that bleeding. Hopefully, you have a commercial tourniquet. At the very least, you want to apply direct pressure. Get on top of it. If it's a femoral bleed, if it's an arterial bleed, put your knee on it, put as much pressure, get your entire weight on that to slow the bleeding as much as possible while you try and figure out how you're going to stop the bleeding. If it's a femoral bleed, if it's an arterial bleed, direct pressure is not going to be enough to stop this bleeding. You might be able to do a pressure bandage, maybe, but the go-to is going to be a commercial tourniquet. You need to stop the bleeding above the injury site. It's going to go 1 to 2 inches above the injury and not over a joint, and you're going to crank it down as much as possible. Most people do not crank a tourniquet enough. If the person is awake and conscious, it is going to be extremely painful. You are going to crank this until the bleeding stops. That is not going to be a pleasant sensation for the person you're cranking down on. But if you take it too slow, you don't tighten it enough, they will bleed to death. Sometimes you can't stop a femoral bleed with a single tourniquet. You may need a second one above the first tourniquet, especially the older cat tourniquets. The recommendation was two on a femoral bleed. The newer ones, in theory, can hopefully stop with one, but again, it's better to have two tourniquets than one, just in case you're in that kind of situation. Let them know this is going to hurt, but if I don't do this, you will bleed to death. And I'm sorry. I'm assuming you want me to save your life. So this is going to hurt. I apologize, but we're going to get you through this, hopefully. Maybe don't add the hopefully at the end. Talk to your patient. They're not an inanimate object. They're not a card. They're not um, a triage tag. They're a real live person, and you're trying to help them, but it's the worst day of their life, and they don't know what's going on. And if you don't talk to them, you don't treat them like a real person, it's only worse for them. Are they breathing too fast or too slow? Well, there's not too much we can do here at this level. You probably don't have oxygen on you. You probably don't have an augmented airway, such as a nasal or pharyngeal airway to help keep their airway open. You probably don't have a BVM, a bag valve mask. Um, what you can do is try and encourage them to take deep, slow breaths. When someone goes into a fight or flight mode, a lot of times they start to hyperventilate. They're breathing faster because the body thinks it needs more air, more oxygen. Their brain demands it to think about what's going on. But the reality is they're not getting enough oxygen because they're breathing too fast and not deeply enough. And so by just encouraging them, say, hold my hands. All right, follow me. Take a deep breath in and out. It might calm them down enough that they actually start to slow their breathing and start taking deeper breaths. That whole thing about breathing into a paper bag, it's not real, but it's the act of thinking about trying to inflate this paper bag with deep exhales, which means I need a deep exhale, deep inhale, that helps to calm them down. The bag itself isn't what is calming them down. It's the act of thinking about and trying to breathe deeply and slowly. If they are actually in respiratory distress, you might see someone what's called tripoding, where they're leaning on their knees. They're leaning forward on their knee, hands on their knees. And you'll see someone who's just run a good amount, and they're not used to it, where they will demonstrate this tripoding for you. If they haven't just run a mile, um, and they're tripoding, that's probably a bad sign. And there's not too much you can do about it, but encourage them to continue doing what their body is already doing. And that is trying to get as much oxygen as it can. And that what that tripoding does is it helps open up the lungs and let more air in so they can breathe. And if it helps, it helps. But at this level, you're probably not going to be able to do much more than this. Circulation or treating for shock and hypothermia. This is where we're going to try and keep the body warm. It actually, one of the worst things that can be done is that you lay someone down on the ground on concrete or even dirt, because it pulls heat away from the body. However, when you're treating someone, you're probably going to have them lay on the ground. If they're laying on a tarp, that tarp is not going to offer much insulation from the ground. The ground will actually pull heat away from the body. If they're already in shock, they don't have good circulation, it will pull heat away from the body faster than we would like. And additionally, you also have to keep them from getting burned. If it is 110 degrees out, that concrete is probably 150 degrees, 160, and can actually cause burns and make the situation worse. So it's not just keeping the patient warm, but keeping them stable, keeping their temperature stable. Thermal blankets are a good thing here. Wool blankets, something you probably don't have it, or if you do, you have a limited supply, but you're going to have to figure this one out. But letting someone who is in shock um, not keep their temperature stable will accelerate their decline. Those were the life threats. Once you have the primary assessment done, you've assessed them. Um, Part of the primary assessment for EMTs is getting the vitals. That's getting the number of respirations, how many times a minute they are breathing, and their pulse rate. Also their blood pressure. At our level, at the CERT level, we are not as concerned about vitals. However, if you have additional training, this might be part of your protocol. Um, that's part of the primary assessment. The secondary assessment is now that you're safe, now that they're safe, and you have more time to assess this patient, um, we want to get the complete picture. We want to make sure that um, we didn't miss anything. And so you're going to extract them from whatever disaster they were in. Um, you want to set up a safe location close to the disaster, but outside the immediate disaster and risk of that disaster. And then you're going to do that secondary assessment. You're going to look for any possible additional life threats. You're going to stabilize any injuries. You're going to treat any minor injuries that you can treat. And you're going to prioritize how quickly do we need to get this person to the hospital? Do we need to get them now? Or That person over there needs to go now. This person can wait a few more minutes. Um, One thing that you don't necessarily do in a primary assessment, but you do at a secondary level is observe the patient's overall disposition. That means this person looks like they just woke up from a bender. This person looks sick. This person looks jacked up. This person looks like they went 10 rounds with Muhammad Ali and did not win. Or maybe they did win, but they're also not in good shape. Um, you're going to look at skin color. Skin color tells us a lot. Most people um, have some sort of skin color to them. It doesn't matter how light or dark your skin is, it has color. And when it doesn't, it's ashen, it's gray, it's pale. And even if you are of the darker complexion, it will still be ashen gray or pale. And it's very obvious. And that means that things are not good for this person. Usually it has to do with circulation, but it could be respirations. If someone is not breathing, they're not getting enough oxygen, their skin goes pale, blue even. If they are bleeding out and they are not getting enough skin perfusion, it will be pale, it will be ashen. I don't know if it's going to be blue. Yeah, it'll probably be blue. But it'll be very obvious that something is wrong here. That is just looking at the person. If you look at the person and go, oh my God, that's bad, that is part of your secondary assessment. And this is probably part of your primary assessment. When you looked at someone and said, ooh, this is not good, you're already starting that patient assessment. If they are sweating excessively and they can't stop sweating, again, this is not a good sign. If someone is panting and sweating and pale, these are all really bad signs. But if someone looks normal, that's also part of your patient assessment. You're looking at someone and go, they look okay, but are we missing anything? Talk to your patient, introduce yourself, ask them if anything hurts, if anything feels wrong, what's going on. Hopefully you have a little bit more time here. Remember, you probably don't have all the time in the world, especially if you're on a TARP with 20 other patients and you're the only responder there. You don't have all the time in the world, but take a little bit of time and treat the patient, not the symptoms. You don't have, in the real world, there's no triage card hanging around this person's neck that you're going to be reading. And so I want you to treat drills and exercises like they're real. Introduce yourself, talk to them. You might look at the card and see what it says, but go through all the motions and treat this like it's real. Don't read the card and just treat the injuries that the card says they have. When you ask them where it hurts and how it hurts, it's how severe is it on a scale from 1 to 10, 10 being the worst pain ever, 1 being was a paper cut. What is the quality of it? How does it hurt? Is it stabbing? Is it pulsating? Is it pounding? Describe the pain. Document this. Radiation, this is not like nuclear radiation. This is, does the pain radiate from a certain point? Does it radiate out? Is it like it's strobing out from a certain point? Does it get worse when you're doing something? If they move their arm and it's a stabbing pain every time they move their arm, one, tell them not to move their arm, but that gives you a clue of where the pain is and what the problem is, or where the problem is. Explain, uh, this is a pet peeve of mine. Before you touch someone, explain what you're about to do, because this is the worst day of their life, and they don't need someone doing something unexpected that causes them to panic. It's going to make them worse. This is particularly a case when you have a difference in gender. And, if you happen to be 6'5" and she is 4 foot, that size difference is massive. And you don't want to look like some sort of wrestler that's about to, rip someone apart. Just talk to them. Treat your patient like a patient. Explain to them what you're doing before you do it. Make sure they are okay with you doing this. If they say no, they pull away from you, don't do it. Don't push it. Don't make the situation worse by forcing yourself upon someone. Don't make the situation worse for yourself because the camera that's recording you sees you doing something that you didn't actually do, didn't intend to do. The angle is going to be bad and might be incriminating. But if you explain what you do ahead of time, it puts the person at ease and narrates to the video that's recording you what you're doing. Treat the patient, not the injury. When you do a head to toe, you're going to palpate, that's touch, and you're going to explain what you're doing. I'm going to perform a head to toe assessment on you. I need to touch your head. I need to find out if we missed anything or there's any other injuries that we haven't seen yet. I'm going to touch at the top of your head and work my way down. I'm going to touch the bony surfaces. I'm going to look inside the ears, inside your nose, inside your mouth. I'm going to look underneath the eyes. I'm going to look in the eyes. If you have a blown pupil, that's a problem, especially if one is blown and one isn't. If you have pinpoint pupils, maybe the person's on drugs. If both pupils are open and you have a pen light, or you can cover one eye and then the other and let the pupil should respond um, at the same size and level and speed to the additional light. That's normal. If they don't, something else is going on here. You need to document it and be concerned about it. If you see liquid coming out of the ears, nose, if you see broken teeth inside the mouth, you have concerns. Liquid, especially if it's clear and has a drop of blood in it, is cerebral spinal fluid. Something is leaking out of their head. That's a problem. Increases the priority. They need to go to the hospital now. If you see broken teeth, and you don't see the teeth on the floor around you, there's a concern that maybe those teeth have gone into their airway and might be occluding it. Or certainly if there's a loose tooth or something, that's a concern. You're not going to pull the tooth out. You're not going to reach into someone's mouth with your fingers, but you need to be aware of these things. These are the kinds of things you're looking for. You're going to go down the center of their body. You're going to, especially if it's a woman, doesn't matter if you're a man or a woman, um, if this person has breasts, you're not going to grab like this and assess them like this. You're going to use the blade of your hand. You're going to go down the center of their chest. You're pushing against their chest bone and making sure it's stable. If it feels off or make sure you are watching their face as you touch them. As you're telling them what you're doing, you're looking periodically at their face. Because a lot of times, people, especially older people, are good at masking pain. They won't say, "Oh, that hurts." You will notice the grimace. You will notice the flinch. And then you ask them, "Hey, did that hurt? If I did that, does that hurt?" Um, because especially older people are conditioned not to complain about pain. However, that's what we're looking for. We're looking for pain. We're looking to see, is something wrong that we missed that might make you need to go to the hospital right now. Um, as you're doing this and assessing, you have gloves on, check periodically. that there's not blood on the
Switch it
gloves from
over.
where you just touched.
I need to know how to turn this off. It's not obvious how you turn off the computer when you're done with it.
Sorry about that. Should have turned off the ability to allow people to unmute themselves. Um, when someone tells you that they have a pain, especially when you get to the abdomen and they say, I have a stabbing pain here, that is not the first place you start touching. You're going to divide. This is not so much how to do a head to toe. It's more of a bigger picture thing. But when you're doing the head to toe and you're palpating, you divide the the abdomen into quadrants, and you're going to palpate each quadrant to get an idea of where possible internal injuries are. Um, if they say they have a pain somewhere, don't go pushing it. They already know they have pain there. You already know they have pain there. Something is wrong at that point. You don't need to reaffirm that. They've already told you. Avoid the area. We don't want to make this problem worse. Check the other areas to find maybe they have a pain they didn't know about. They knew about that pain. The other pain, when you palpated that, they weren't aware of that until you discovered it. And this got me when I did my emergency medical responder training, is I forgot to check the back. Yes, I found something obvious. I treated the obvious injury and I stopped there. I forgot to treat the patient, not the injury. So you want to make sure you roll the person on their side, do a quick sweep of the back. You're looking for any blood on your gloves. You should have clean gloves before you do this. So if there is blood on your glove, you missed an injury on the back. Now you got to go looking for it. Find out what this is. Find out if this is life-threatening. When you do the secondary assessment, when you find an injury, you can either treat it right then and there if it is something severe. You got to this point and maybe whatever was holding in the blood came loose. And now you see a pool of red forming, or you see something start spurting. Do something about that. Don't complete the assessment and then go back to it. You find a hole in the chest or the abdomen, do something about it. Cover it. Um, a hole in the chest can easily become a collapsed lung, and you need to do something about it. And this is where you have to start taking more advanced first aid training. Um, Even basic first aid now starts talking about higher level interventions here, where you need to do a occlusive dressing or a chest seal on an open hole in the chest cavity. Same thing, you find a hole in the abdomen, cover it, do something about it. You find a paper cut on the person and it's bleeding a little bit, that can wait. But if you find something bad, do something about it now and then continue with your assessment. Find out if you missed anything else. You find a dislocation, a sprain, a broken bone, an impalement. Stabilize the impalement. A broken bone, don't make it worse. Sprain, don't make it worse. Dislocation, don't make it worse. But you can treat that later. Um, a lot of times, maybe we can't. If we don't have the equipment, we don't have something to do something about it. But the person will naturally position themselves in a position of comfort. If they are grabbing their leg and they're on their side because their knee is dislocated and they're holding it up against their chest, Don't make them lie flat on their back if it causes them pain. Let them be in the position of comfort, assess around them. If you have an impalement, stabilize it the best you can so it doesn't get worse. You're not going to pull out an impaled object unless it's preventing you from doing CPR on them, or you need to get this person out of there because it is now unsafe. But for almost all circumstances, you're going to leave that impaled object in there. If the scene is safe, you're going to leave them on whatever is impaled on them until professionals can deal with this. If someone is unconscious, you're going to put them into the recovery position before you tend to any other patients. And this is because, unfortunately, again, we don't talk about these things in the basic training. Most people in a trauma will vomit. And if they are lying on their back and they vomit, it has no place to go except back down the airway and into their lungs. And they will aspirate and they will die or get very sick and become way worse. So, by putting someone in the recovery position before you move to the next patient, you preserve the chance of them getting rid of that vomit out of their body. You're going to reassess. For someone who is unstable, you're going to reassess them every 5 minutes, ideally. If you're the only person on the tarp and there's 20 patients there, 5 minutes ain't going to happen. But ideally, you're going to reassess. And for CERT level, you're doing 32 can do. Check their respirations. Are they suddenly breathing a lot faster than they were? Their capillary refill is now greater than 2 seconds. They can no longer follow directions. Now you've got a problem. However, if it is still normal, then okay, hopefully nothing is worse. Talk to your patient though. Maybe they say, "Oh, I've got this headache and it's now pounding. I didn't have this headache before." Okay, that's not great. If you are a more advanced medical provider, that reassessing is going to be vitals. You're checking for the pulse, you're counting respirations, and you're taking blood pressure. If things are getting worse, those are going to show in the vitals that things are getting worse. For people who are stable, patients who are stable, you're going to reassess them every 15 minutes. Again, you do what you can with the resources you have. The recovery position is going to be if the person's laying on their back, they're going to tilt the head backwards to ensure that the airway is clear, and you're going to straighten the head and neck unless you suspect trauma to the head, neck, or spine. Then you're going to be very careful about this. You're not going to extend the neck and cause or risk causing um, additional trauma. You're going to place the arm, and generally speaking, you're going to roll this person on their left side. The left side is because um, the heart is slightly to the left, and so it's closer to the ground. Oh, no, it's slightly to the right. Yeah, sorry about that. Slightly to the right, and so when they're on their left side, it has less mass pushing down on the heart. Um, so you're going to place arm at the side and the other arm over their side, other arm up against their cheek. Yeah. Um, I haven't really had to do the recovery position on myself, so that's you can see in the picture here. Bring the far knee up at a 90-degree angle, and then you're going to roll the person towards you. So you're going to be on their left side. You're going to roll them towards you. So the knee is at an angle, holding their body up so it doesn't roll over flat on their stomach, and that their hand is going to um, cradle their head so it's not at a weird angle. And again, so they don't roll flat on their stomach because if they vomit, they'll aspirate that way as well. And If they have some sort of impalement or pain and something you can't roll them on their left side, roll them on the right side. But ideally, it's going to be on the left. Do what you have to do for your patient. Treat the patient, not the symptoms, not the injuries. Do what you have to do to make sure they are, you know, if you have to roll them on the right side, that's fine. Medical treatment area, also known as medical triage, medical TARPs, TARP treatment, medical whatever you call it, it doesn't matter. All it is an organizational tool to help make clear who the injured survivors are and patients are and what their severity is. Generally speaking, the easiest way to do that is to lay out color-coded tarps. However, if you don't have color-coded tarps, and you have maybe triage tape, you can cordon off an area with the tape to denote this is the red area, the immediate area. This is the yellow, the delayed area. Do what you can with the resources you have. Not all of us can afford to have a bunch of tarps. Not all of us have a bunch of tarps. Maybe you have a bunch of blue tarps, but you wanted to note the different areas for treatment because if you have incoming, more patients coming out of a disaster area, the rescuers bringing them out need to know where they're going to go. If I have someone who's an immediate, I need to take them to the red tarp. If all the tarps are blue, I need to take them to the immediate treatment area. Where is that? What does that look like? Um, and it's simply an area where CERT will treat and monitor the injured and prioritize and plan the transport to definitive care. The color codes are fairly simple. Red is immediate, means this person needs to go to the hospital in the next 60 minutes or they will die on us. Things are bad for this person. Yellow is delayed. We're not sure entirely why they didn't self-evacuate. They don't seem to be in immediate danger of dying on us. They appear to be relatively stable, but potentially injured. Yellow tarp. Green, walking wounded. You don't necessarily need a tarp for the green. However, if you have people coming to you asking for help and they're not immediate or delayed, they're green. Put them somewhere, treat them, make them feel better. Maybe they have a cut and it's pretty severe and they need butterflies, butterflies or stitches or just bandaging and dressing. Probably going to happen at the green tarp. Put them somewhere where you can treat them and make them feel better. The black tarp is where you will put people who die, expire, decease on you at your tarps. Probably from the red tarp. Hopefully not from the yellow or green tarp. If someone die, you get to them in the disaster area and they are dead, you leave them there. But if you are working on them and they don't make it, you don't want to leave them on your tarp with your live patients. You need to move them somewhere out of visual range of all the people who are having really bad days and hopefully will continue to have bad days, but continue having days. Um, it's not going to be a great situation where you lift up a dead body and pull them off the tarp. This is not going to be something that any of us want to experience or can even really contemplate, but it needs to happen. You need to provide security for the black tarp. One, you don't want people taking advantage of the situation and looting the dead. Two, what if they're not dead and they start screaming for help or um, magically awaken and sit up? Yeah, then that happens. Um, so someone needs to be there with them and get them back over to the red tarp. Fire department does this, maybe on a freeway. They're going to do it where they need to do it. They're also going to set up the tarps. In this particular incident, they did not need the tarps, but they set them up ahead of time in case they needed them. And they pre-positioned resources. And if you look at this, where are the ambulances in relationship to the red tarp? They're backed up to it. They're not right on top of it where their fumes would be, you know, spraying the people who are on the red tarp, but they're backed up to it so they can get out of there quickly with someone who needs to go to the hospital. And they're positioned in a way that they can just drive off. Mostly. Um, one of them, two of them can get out of there. The other two might have a problem. But that's the kind of thinking you're doing when you're figuring out where am I going to put the tarps? Where are we going to position our medical treatment area? Planning and tracking is critical. It is not the only thing you think about, but it should be part of the plan. Um, you want to plan ingress and egress ahead of time. I will tell you that um, if you have your medical tarps in a field and there are people coming in from all directions, that chaos is going to be very difficult to control. But if you can direct your incoming in one direction, say you have to come this way so we can assess them and process them and intake them, you will be able to track how many patients you have on your tarps a lot easier than if there are 5 different teams or 20 different teams dropping people off left, right, center, above, below, and I have no idea at any given time how many patients we have. And this is something you want to plan before you get overwhelmed, because once you get overwhelmed, it's already too late. Generally speaking, you have a little bit of time, a little bit of build up before you get inundated with a bunch of bodies on the tarps. So, where are we putting the tarps? How are we tracking who we have on the tarps? Where did they come from? If you have people, you're in a community, multiple blocks, and you have people on the tarps who are unconscious. Where did they come from? That information is very critical because you pull them out of a building, they're not going to be able to answer if they're unconscious. And it's good to get this information before someone goes unconscious. That's part of that patient assessment. And once they go unconscious, then you lose that opportunity to get that information. Where do they come from, but where are they going as well? We transport them to a hospital, either in a rescue ambulance or in the back of someone's station wagon or in the back of a truck. Where are they being taken to? Because if their loved ones come looking for them, they have nowhere to look if we don't know where they went. Where are we taking the most immediate injured first? Is there a local hospital? Is there a veterinarian clinic? Is there an urgent care? Where are we taking these people? This is something we need to figure out before we start getting bodies on the tarps. We need to figure this out and plan. And maybe option A is not available. Maybe option B is not available. Maybe you have to go to option C or option D. But come up with that plan ahead of time. Because once you get overwhelmed, it's now too late to start thinking about what are we going to do? Who is transporting them if the professionals aren't available? Yeah, it's ideal if the fire department comes and picks up because it's their problem now. We don't have to worry about them if the fire department takes them. But if the fire department's not available and we have to transport or we have to have our neighbors transport, who's going to do that? How is that going to look? Are we going to have medical people go with them? Because if someone's unstable and bleeding out, you're not going to just throw them in the back of a truck without anybody there and hope that truck makes it to the hospital before the patient expires on you or on them. That'd be horrible. You think you're doing great. You're driving someone in the back of your pickup truck. You get to the hospital. They died 20 minutes ago, and you didn't realize it because no one was with them. That is one thing we are really bad at in our drills is making sure we are treating and staying with the patients as we transport. Hopefully, you give them to the fire department and they take care of this. But what happens if that's not available? And how are we getting them to that hospital or to that definitive care? Patient tracking is something we also not do great at. If you look at what the fire department did, they have triage tags, a tag with a number on it and a secondary tag that they're able to keep so they can identify how many immediates do they have and track the numbers. Those are like $5 a piece. I'm not buying those. And I hope most of you don't either, unless you have plenty of money. And then great, cool. Can I have some? I will take some triage tags from you for sure. Um, but what we can do is we can do triage tape. That's just flagging tape in those colors. Or what previous Central Bureau came coordinator came up with is um, these things. These are wristbands that you use for parties or events, so you can track who was there. These have numbers on them. Well, you can get them without the numbers, but you can get them with numbers on them. And then you have a number, a unique number that you can track. And why is it critical to track? Because if that person is unconscious, where do they come from? Where did you find them? And what was the state that you found them in? If they weren't unconscious and you got information about them and then you got them on the tarp and then they go unconscious, they can't answer questions anymore. So now you have to go back to any documentation you have about this person. Why are they on my tarp? That is the question that your responders are going to be asking. Well, if they can't answer it themselves, someone needs to answer that question. The team that found them. Yeah, we found him. He was in a building. The building partially collapsed on him. We were able to get him out. It looked like he might have gotten hit in the head with a brick, or he inhaled some smoke, or she tripped and fell and struck her head against a pole. This information needs to get documented and tracked so that you can correlate that information with the body, the living body, hopefully, but the body with a number on it that tracks to the information that you did. Um, if they come to your tarp and they don't have a number on them, give them a number, give them a tag. You need to start tracking this person. This, again, is something we're not great at. If you are the only person on the red tarp and there are 20 patients, do what you can with the resources you have. It's all about controlling chaos, and this is going to be the most chaotic part of it. If you cannot correlate your patients with documentation, there is no control of chaos. There is no organization that you can do. At that point, you are trying to keep as many people alive as possible and any opportunity you can to get them off your tarp and into the back of a vehicle and get them to a hospital. That's all you can do and manage. That's what you can do and manage. But if you have the resources, you have the time, you have the setup and pre-planning, you have these tags and you can tag them and you can document that tag number, you're ahead of the game. Um, in almost all circumstances, the red tarp is going to be the focus of all treatment, all reassessments. You know these people are in danger of dying and they need to go to the hospital. What you can't do is forget that there are other patients who are not on the red tarp. Um, you need to do something about them as well. And maybe, hopefully, your yellows don't become red. And the person who was injured and didn't get off out of the incident when you called to them, you can release them on their own. They're fine, or they can go with a family member or someone who can monitor them. That's the best solution you have right then and there. Maybe they still need to go to the hospital. Maybe they can go with someone who's immediate. You can take two people or three people, get them to the hospital. The green tarp, the walking wounded, treat them and then let them go. Let them go back so you don't have to worry about them, but treat them so their injuries don't get worse. Last month when I was speaking about medical triage, I said that you might have someone who's a parent or a child who is with someone who is immediate, and they're not going to leave their side. They might be fine. They might be delayed because they're with someone who is immediate and they're not going to leave. I said to mark them as you triage them, and that would be delayed. I was speaking to a CERT instructor who said, no, you're going to triage them the same color as the person they're with. And that is because you don't want to separate them. You don't want that confusion. You don't want, say, a parent who's unconscious to go to the red tarp and then their young child who really can't argue for themselves gets separated and forced to the yellow tarp. So if you find this situation, you're going to triage them both the same color so that they end up in the same place. Track your patients as best you can. Ideally, clipboard paper, even blank paper. But if you have the correct forms, you can track them that way. But you need to track them or you have no control of this chaos. If you have a dry erase board as well as the clipboards, who is on my tarp right now? Who is on my red tarp right now? Fire department shows up and says, who are the priorities? And I have a dry erase board and it shows the patient numbers and their severity, their priority. This person needs to go first, this person needs to go second, this person needs to go third. You're ahead of the game. That is what controlling the chaos looks like. Always anticipate you're going to have a full tarp. Um, so what we see all the time is the first person who gets to the tarp gets dropped in the center of the tarp. Well, that doesn't work if you have more people coming in. So you want to start by placing your patients in one corner. You're going to place them head to toe, head to toe, head to toe. You're going to place them close together, but not on top of each other. You want to be able to have the responders be able to move around this person, but you also want to have enough room in case this person rolls over or vomits or something else that they're not right next to someone else because things like this happen to have a chain reaction capability. And that is not great when one person vomits and then the next person and then the next person and the next person and then you do as well. Um, but at the same time, don't have huge gaps either. You need to get as many people on this tarp as you need to, but also don't overforce it. If you need to expand off the tarp, then do so. If you need to bring in additional tarps and you have additional tarps, then do so. But plan accordingly and plan to have more than just one person on the tarp. Most tarps can handle about 10 people. That it's simming about a 20-foot by 16-foot tarp. That's about a 6-foot person by about 2 feet wide, with about a 2-foot gap in between and a 3-foot gap between. But you can see this layout, how this looks with the head to toe, head to toe, head to toe, head to toe setup. That way, if one person vomits, they're vomiting at someone else's feet and not right next to someone else's head. Some tarps will actually have a layout so you don't have to think about how I'm going to lay people out with numbers like this. But sometimes it's just a colored tarp, literally. Where and when you're going to place the tarps. We've seen this done um, in creative ways at our drills. Um, First of all, where do you think you need them? Just don't overthink it. If you think you need them here, set them up here. If you have the people, the resources, and time, put the tarps out ahead of time. As we saw with what the fire department did, they pre-staged the treatment area. They never ended up using it. That was great because if they did need it, they didn't have to now take the time, energy, and resources to set it up while they have bodies already piling up and needing to go there. If you don't have the time, then set it up when you need it. But um, don't waste resources trying to set up the tarps that if you don't have the resources. You want to be close to the mass injury incident. You want, because if they're pulling them out of a building, you want them to be close so they don't have to walk a half mile or 3 blocks to get to the treatment area while they're carrying someone and risk dropping them. Um, place, you want a flat, relatively flat surface that's solid. A muddy, marshy dirt lot is maybe not the best. However, on concrete in the middle of the street is also not a great solution either. Um, it needs to be stable and safe. We've seen people put tarps at angles on rocks, and we've seen people put tarps on top of rocks. It needs to be free of hazards, uh, rocks, debris, stuff like that. You don't want to cause injury to the people you're trying to help when they get laid down on something sharp or pointy. If you have a pre-planned neighborhood location where the survivors are going to be brought to in your community, then it should be central to that community, but close to a major street because you want to have that plan of how are we getting them off the tarps. And if an ambulance is going to come, they're going to come to the major street. They're not going to go um, 15 small streets down to find where you set up the tarps. You want to get them out there quickly. And the red tarp is going to be closest to where the ambulances are going to pull up, or a vehicle is going to pull up so you can quickly lift someone and then get them into the ambulance, back seat, bed of a truck, whatever it is. You don't want to have to carry them a huge distance to get to that vehicle. Ideal setup would be something like this, where you have the street. That's going to be where the ambulance or um, case vac civilian vehicle is going to go. Red tarp's going to be right there. Your delayed is going to be close by, and your walking wound is going to be a little bit farther away. The way I would set this up is I'm going to have incoming um, from one location, one direction, goes in. I'm going to have a treatment group supervisor, scribe, and radio communication person there doing the intake. And this is so we have an idea of who is on our tarps and where are they and the severity. We do a quick assessment here. Okay, they've been tagged red. Yeah, that looks bad. What's their number? Their tag number. Okay, take them over to the immediate. They're going to go to the red tarp leader, who's going to go, yep, that looks bad. Put them here. What's their number? Document it so that your immediate tarp scribe and your scribe for the treatment group have the same information. It should correlate. If there's difference in information, you're not controlling the chaos very well here. The better the organization and pre-planning is, the less chaotic it will be. It will still be chaotic. It will still be chaos. All emergencies, all disasters are chaos. But what are we trying to do? We're trying to control the chaos. So that pre-planning and pre-organization will help go a long way towards that. Control the entry. If they're coming from all directions, you have no way to control this. You have no way of knowing who is on my tarps. How many do I have? What are their conditions? They need to come in one way. If they're coming in from all directions, it's going to be too easy to miss new patients. You won't know that you have someone there. And when the fire department shows up or you get a vehicle available and they say, who needs to go? You're not going to have a good answer for them. Um, Worst case scenario, you have a red tarp and that's all you have. And then you're doing what you can with the resources you have. Set that up first. If you have time, set up a yellow tarp. Um, Maybe you don't have staff on that yellow tarp yet, but hopefully more people will show up that can help, and you can put one person or two people on that yellow tarp. Don't forget about the people on the yellow tarp. Don't forget about the people on the green tarp. Each tarp should have a tarp leader and scribe. They're the ones who are tracking who and prioritizing who is on the tarp and who needs to go to the hospital first. You're going to be constantly retriaging. Ideally, you're unstable every 5 minutes. You're more stable, we're going to get reassessed, retriaged every 15 minutes. Um, if they're on the yellow tarp and the tarp leader goes, this person is um, getting worse, we need to move them to the red tarp. That needs to go in a formal process. You don't just transport tarp to tarp. That TARP, that treatment group supervisor really needs to have that big picture. I need to know who's on each of my tarps. And if I have yellow going to red directly, then I don't know. I thought this person was on yellow. I didn't realize they got moved on to red. And now suddenly they are now the priority that needs to go to the hospital. But I didn't know that. And therefore, I didn't prioritize them as that. That TARP leader needs to say to the group supervisor, hey, I need to move this person. Group supervisor agrees and tells the and makes that facilitates that move, but tracks it so that you know, okay, yellow number is now on red. And then put a new wristband, put an additional red wristband on them. Don't take the yellow wristband off because that wristband, that number goes along with the documentation. And if you rip off the yellow and that number, throw it away and put a red on, you now have no documentation for this person. And if they are unconscious, you have no way of knowing where this person came from. When a patient arrives at the TARP, if you're the TARP responder, you're the hands-on, you're the person doing medical, you're going to treat any obvious and immediate life threats. You're going to perform head to toe and find any secondary injuries. You're going to prioritize stabilizing injuries such as impalements, open wounds, bleeding, any airway issues. You're going to keep your patients warm as best you can. Again, if something has gone wrong, they are probably going to go into shock, especially with trauma. And the best thing, the only thing we can do to treat trauma or stabilize for trauma is keep that body warm. Keep the temperature stable as best as you can. Don't forget about that. You're going to let patients rest in the position of comfort. If it hurts to be on their side, it hurts to be on flat on their back, then let them do what feels comfortable for them because they know their body better than you do. You're going to place unconscious patients in the left lateral or recovery position if you can, if not on their right side, on the right lateral. And then you're going to form the TARP leader if any patients are unstable or getting worse. And then rotate through in an organized fashion. Reassessing again, unstable every 5 minutes, more stable every 15, but do what you can with the resources you have. Oh, was weird. If you're the TARP leader, you're going to visually reassess a patient as they arrive and confirm that they're arriving at the correct TARP. You're going to have the scribe document the patient tag and time in. And you're going to direct where this patient is going to get placed. I don't want to say dropped, placed. Um, and make sure that the people bringing your patients in do the work. They're not, when we have drills and people are literally being walked in, that team shows up, says, okay, go over to the red tarp, and then they leave. No, that team that's bringing in the patient, especially if they're on a stretcher or something, need to place the patient down and get them off and make sure that there's a good handoff here. Don't let them leave without that good handoff. And they're talking to the TARP responders and prioritizing who needs to transport first. Your TARP responders are going to know this person is really, really bad. This person's only really bad. The person who's really, really bad needs to go first. Then the really bad person needs to go second. Additionally, do we need additional resources? Have we used up all of our gauze and bandages and we need more? Or, as probably happens, we need more people on the red tarp helping out. TARP group supervisor. And you see how we build here. We build from the TARP responder. You have a red tarp and one TARP responder, and that's all you have. That's all you have. If you have a couple TARP responders and now a TARP leader, that is what you have. If you have enough resources, enough people here, that you can actually have the TARP responders, TARP leaders, and a TARP group supervisor, treatment group supervisor, you're better controlling chaos at this point. This treatment group supervisor is going to be hopefully listening to the radio communication. Hopefully your teams in the field are reporting in, hey, we have a survivor here. They're immediate. We assigned them this patient ID, this tag number, and we're taking them to the treatment area. Okay. As treatment group supervisor, you're listening to the radio communication and going, or your radio person is, and going, okay, we have an incoming. We're expecting them to go to the red tarp, and this is their number. We can document this ahead of time. What happens if the team calls in with a patient number and that patient never shows up? Well, that's a problem, right? Did they never make it? Did they go to the wrong tarp? Did that team never make it here? What happened? We're missing some information. But when they show up, you've already documented that patient number. Go, okay, we've already written down the number. We reassess them, visually reassess. Go, yes, this person looks like they're immediate. They need to go to the red tarp. We have their tarp number and we have them on the board and the time in, what time they actually got there, not the time they called in and said they were coming, but the time that they arrived. And then you direct them over to the tarp leader who will place them on the tarp. Um, You may, depending on the resources, have a red tarp leader, but not a yellow or green tarp leader. Again, resources you have, the priority is red, but don't forget about yellow and green. Now, here's where that treatment group supervisor is key. Start working on the plan to get the patients off the red tarp and the yellow tarp and the green tarp. Got to prioritize, but have that plan. Are we calling fire department? Well, if we can't get a hold of the fire department, can we send people door to door asking neighbors who have vehicles, can you take someone to the hospital for us? And you're working with the TARP leaders to prioritize that transport and also finding out if they need additional resources and supplies. Paperwork, this is CERT Form 5. I'm not a big fan of this. There's a lot of blank space here. But triage tag number, name or description, that would be the tag number, time in, condition or treatment, and you're updating here. And then when they leave, where did they go to and what time did they leave you? I like this Lamorina Rita cert form because it's more condensed. There's not a lot. We can put more people on here than have a lot of three patient forms. But do what your local protocol is. Do what form makes sense to you. Our Valley Bureau coordinator um, keeps asking about the ICS 214. It is not taught in CERT, to my knowledge. Not in the basic class. If your training has added the 214, great. All emergency management classes I've taken have included the 214. So I agree, it is something that we should understand and start teaching too. And I'm adding it into this presentation just because of that. It is basically an activity log of what you did. This is your log. What time did you arrive? What position were you? Um, and then notable activities, time and date. What's going on? At the very least, if you have a 214, you can document everything on here. And so it's good to start practicing with this form, but a blank sheet of paper works just as well. All right, end goal. It's a long presentation. I apologize. But the end goal of the medical treatment area is get everyone off the tarps. You have to have this plan ahead of time, during, otherwise you'll never get there. If you don't know what the goal is, how are you going to get to that goal? Transport the immediate to definitive care. It's going to be a hospital or some sort of professional medical center where you can send them to, where they can be hopefully saved. Delayed, send them either to a professional medical center or home with someone else who can monitor them to make sure they don't get worse. The greens, unless, they need to go to the hospital, send them home. They don't want to go to the hospital. The hospital's going to be busy. Sunday, April 26th, 7:30 to 1:30 p.m. It's an early morning. This is the QR code that'll take you to the Eventbrite. This Eventbrite shows as full. But sign up for the wait list. Just plan to show up. I've never seen them turn away people. However, it is CERT graduates only. And if you are from outside LA City, you're welcome to attend. We have a lot of people coming from Pasadena, Burbank, Glendale, Alhambra, Monterey Park. All are welcome. It's at LAFD Fire Station 88, 5101 North Sepulveda Boulevard in Sherman Oaks. You must, absolutely must have closed-toed shoes and long pants. That is a must. You will not be allowed to participate if you do not. And it is stacked parking. If you get there and you do not, you have sandals on, you're stuck there until the end of the refresher. Bring a helmet, goggles, gloves, your go bag, your CERT bag, whatever, gloves. Bring your lunch and drinks. All right. We lost quite a few people here. Um, I have not had a chance to read the chat. Hopefully some of our coordinators and more experienced people have been. But do you have any questions? This is a lot of information that we've just thrown at you. This is on our CERT coordinators YouTube channel. So if you need to go back and watch it or you want to share this with people, go ahead and do so. You just go to YouTube, search for CERT coordinators, and you'll find it on our live section. But any questions? Jose, are you still here? Brisa, Breezy.
Hi.
Hi.
Great class. Thank you for doing this. I just have a quick question
Hmm.
about the Good Samaritan law as far
Yeah.
as asking neighbors to transport because that's something that's been heavy on my mind. If the EMTs are overwhelmed, how can I convince my neighbors like, hey, you're covered, it's okay, this is Good Samaritan law? Is because I know if you are CERT graduate, I guess we're like under the insurance, depending on the sheriff or whoever is, how like for Altadena, we have the Altadena Sheriff insurance,
Mhm.
right? That kind of covers us when we're out in the field. So I'm curious, how can we reassure our neighbors when we're like, hey, we're triaging here. We need somebody to get to the hospital now. You don't have to worry. You're covered. What's the gray area there?
So the Good Samaritan law, and all states have a similar law, basically says if you help someone out of the goodness of your heart for no compensation and no return, um, you are not liable for, and you operate within your scope of training, you are not liable for any injuries or if you make them worse. Um, the gray area is that doesn't mean they can't sue you. Just look around, see how many billboards there are for accident attorneys or attorneys who say, "Who hurt you?" and we'll make you a millionaire. Um, you need to be able to justify your actions. If definitely do not accept a cup of coffee or a thank you, or I mean, a thank you is fine, but um, there was an example, I think, in the Altadena class actually, where that, oh, we were gonna go to a Laker game and now we can't. Here are the tickets. You can go. That makes you liable. Um, I don't know. I don't know how to answer that in a way other than understand what you're doing. Um, don't do something stupid and don't accept any compensation and be able to justify your actions in a court of law. I don't know if that was the answer you're looking for, but that's the best one I can give. Any other questions? A lot of people asking, where is this going to be? Um, Charlotte is asking, do you recommend keeping your trauma kit equipment in from keeping your trauma kit equipment from the regular CERT bag, away from the regular CERT bag? Um, a regular CERT bag or go bag is going to be multi-purpose, should have a first aid kit in it. I would have a more dedicated or bigger first aid kit or trauma bag separate from my go bag or CERT bag. Because if I need to grab that, I don't necessarily need a tool to shut off gas. I don't necessarily need, MREs or extra water. What I need is a well-organized trauma bag so that while I'm helping someone doing first aid on them, I can find what I need. Any other questions? And again, a lot of information here. This was definitely one of the definite fire hose ones, where I gave you a lot of information. So I would highly recommend you go to our YouTube channel, search for LAFD CERT coordinators. I can put that in the chat. And you'll find our channel there. And you can rewatch this video over time in smaller doses. Um, but I wanted to give you a big overview of this topic. And I wanted to emphasize a few things, and that really is that triage, a patient assessment is ongoing. You will constantly be redoing it. And don't let yourself become too focused on one thing. You need to have a plan going in there and then be able to adjust and pivot that plan as things change. Um, Stacy Burns is saying that CERT of the villages, Florida members are not fire department employees, volunteers are not insured. Yes, that is absolutely true. If you get sued as a CERT responder in your own community, I would not anticipate that the fire department that trained you, or the emergency management department that trained you, or the police department that trained you is going to step in and defend you from a lawsuit. If you are operating under their control, you volunteer directly for an agency as part of their call-out team or as their vetted volunteers under their direct control, they will probably defend you unless you did something stupid and are grossly negligent, then you're kind of on your own. So, as someone else said in the chat, don't be dumb. Um, don't do something that you are not trained to do. Don't do something that exceeds your level of training. Don't do something risky. Don't do something because you saw it on TV. Eric. Eric, go ahead and unmute and ask your question. Eric?
Oh, hey, Patrick, thank you for the great presentation. This is a subject that I have little familiarity on, so I appreciate the information and thank you for pointing us towards a YouTube as well. But um, to learn more about decontamination sites and how to set those um, those up, is that a topic that you guys cover as well too? Or
I really don't see CERT ever setting a decontamination site. Let the professionals deal with that. That is not
okay,
something that we are trained to do. Um, not as and is not something that we should want to do either. But there's a lot of hazmat training. There's a lot of equipment required for that, and there's a lot of risk. If you don't do something right, you bring victims to the incident, and that is not what CERT is designed for.
alrighty, very good. Thank you for that.
You're welcome. All right, well, it is 9 o'clock. I want to thank you all for sticking around, and then hopefully see you at the refresher in April or April 26th, or see you back here in May for our third Wednesday of the month training in May. Have a good night, everyone. Carrie, go ahead.
There we go. Hi, everyone. This is just my quick little share. I have these tapes. They're a little hard to see with my screen, but this one's a green, this one's black, this one's red, and then this one's yellow. What they're great to do is actually take a string, put it through them, put them on a carabiner clip. And when you have to do the patient assessments, you can use a Sharpie to write on them. They do at least give the colors. It's recommended to put them either around the patient's wrist or ankle. You can write a little bit of information on them. You can keep them a little bit longer with a tag that you can write the updates of times checked. It's just something to consider. They're not expensive. They're easy to strap onto your bag, and just something, like I said, something to consider carrying.
Yeah, absolutely. And they're relatively cheap. You can even buy them at a hardware store. They're called flagging tape.
Thank
can
you
get
for
them at
letting me
authentic.
share.
Yeah, absolutely. Thank you so much. All right. Have a good night, everyone.
Good night, Patrick.
Night, Jose.